marks of the JPS polyp. The colon is involved in virtually all cases, but interestingly, you see more polyps on the right-hand side for reasons that we don't understand. Are they pre-malignant? I think the consensus is that they probably are, and from the series that I've looked at from the St Mark's data, there was an 8% dysplasia rate, which probably would go along with that. Certainly there is an increased risk of colorectal cancer. Exactly what it is, I don't know. I think for those people who've never undergone surveillance or screening, then it probably is about the numbers quoted here of about 30 to 40%. So what's the role of colonoscopy in this syndrome? It's preventing polyp-related complications, so the most common presentation for this is rectal bleeding and anemia. But I think there is a role for cancer prevention and early detection of cancer. Current guidelines would be 1 to 3 colonoscopy depending on the phenotype. So if there's virtually no polyps, leave them for 3 years. Clearly if there's a lot more, you're going to want to repeat it at an earlier stage. When to start is debated. I would say if they're symptomatic, as soon as they're symptomatic, we scope them. Otherwise, people will say maybe 12 years, maybe 15 years, and I think as a ballpark figure that seems very reasonable. So are there outcome data? And again, there is only one series which have given outcome data from colonoscopic surveillance. So in the group from St Mark's, 44 patients, just under 400 years of patient follow-up, 192 lower GI examinations without complications. Interestingly, 11 patients had colonic resections, but all of those predominantly were before they were referred. And these were patients without a family history. They were the first presentation with colorectal cancer or multiple polyps. And most of these people had undergone a colectomy, niorectal anastomosis at other institutions. There were only 2 colorectal resections at St Mark's for the people who were under surveillance. One was an AP resection for somebody who developed rectal cancer, and the other one was a pouch revision. We've had 2 patients develop bowel cancer on surveillance. One of these was in somebody who had carpeting polyps in the rectum. So a lesson there is if you see carpeting polyps, get them to have surgery because you can't survey them endoscopically. The second one was a historical case where they did an incomplete colonoscopy, even though it said they got to the cecum, and 10 months later a bariomenoma in the area of bariomonas saw cecal cancer. So I'll whiz through and hopefully in a timely manner. So this is just a summary slide to give you a flavour. Of note, MAP and FAP, predominant management is surgical. For those that aren't, annual colonoscopies. For all the other syndromes there, the primary management is endoscopic. The intervals, surveillance intervals are on the right. I will just one line about familial colorectal cancer type X. There isn't an accelerated pathway. The cancer risk is much less than Lynch syndrome, and that's why for those there's a 3 to 5 yearly surveillance interval. At the bottom, the P10 hematomatous tumour syndromes. Colorectal cancer isn't the major problem. Breast cancer, thyroid cancer are by far more common. And in the complete absence of data and random number allocation, they've been given a 3 to 5 yearly surveillance interval, but it is purely that. So, thank you very much.